first of all, what's the scope of the problem of dealing with pregnancy during diagnosis and treatment of colorectal cancer? So we know that by all the speakers today that colorectal cancer is increasing in the younger population. That's the focus of this meeting. We also know that cancer during pregnancy is increasing and is expected to further increase with a trend to delay pregnancy to a later age than in prior years. So this is not about colorectal cancer, but this is a fairly recent, just from about 10 days ago, demonstrating that the number of younger women discovering breast cancer during pregnancy and breastfeeding is rising. So it's not by any means a unique problem. So what are the issues that surround this? Well, first of all, there's the issue of clinical suspicion for diagnosis. With pregnancy, certainly many of the symptoms that young women undergo might overlap with symptoms that might occur with diagnosis of colorectal cancer, and thus the diagnosis may in fact be delayed. Then there are also the issues of stage and type of cancer and goals of therapy. So we need to define whether or not we are dealing with adjuvant therapy or disseminated disease. This has time focus associated with it. Certainly we want to begin our adjuvant therapies as close to the recommended time as possible in order to give the young women the best chance at cure with our treatments. At the same time, if we're dealing with disseminated disease, it may depend on the type of cancer, the aggressiveness of the disease, and the need to treat the young woman. Stage of pregnancy is extremely important in this. So the trimester of pregnancy is specific to the kinds of toxicities that might be encountered. And we also have to consider the effect of pregnancy itself on maternal prognosis. There are specific toxicities of specific chemotherapy regimens. So choice of therapy, maybe there are options. Maybe we can find treatments that are less toxic to a specific stage of pregnancy, but maybe we are constrained to a specific regimen. So we certainly are also faced with both chemical and biological chemotherapy agents. And yes, in the realm of immunotherapy, there's starting to be some basic research on immunotherapy in pregnancy, because certainly in the melanoma population, there are plenty of young people for whom this may be a problem. So then when you understand what the toxicities related to a specific drug are, you've got the issue of combinations, because rarely are we dealing with single agent treatment. And not only just the chemotherapies, but the ancillary medicines that we give along with them may have their effects. And then this is an issue that has been discussed quite a bit in this session, which is the effect on siblings and spouse. So surely pregnancy has a lot of stress associated with it, and in young families, and particularly if there are already other children in the family. And certainly having a diagnosis of cancer is very stressful in any setting. And so the siblings and spouse in the family of a young woman who is dealing with cancer treatment and pregnancy are probably more than double. So what are the risks of chemotherapy during pregnancy? How do we know them? What resources do we have to determine them and make treatment plans? So fetal risks occur most significantly in the first trimester, when the risks for spontaneous abortion, the risks of fetal death, and major malformations, which is a significant concern, occur. And it's been estimated that there is a 10 to 25% risk of major malformations, and as you might imagine, higher with combination than with single agent therapy. In the second and third trimester, the risks are more toward intrauterine growth retardation, low birth weight, and premature delivery. And the estimates for these are about 7% for growth retardation, 5% for premature delivery, and 6% of fetal or neonatal death. And this is in what in other areas would be a relatively small population, but is actually a fairly large population for analysis of the effects of chemotherapy in pregnancy. So what are maternal risks? So we have to consider whether or not there is going to be impairment of survival in their cancer diagnosis due to treatment delay. There is also the enhanced physical stress of pregnancy itself, in addition to the enhanced physical toxicity of chemotherapy, and as the theme has been in the past hour or so, certainly enhanced psychosocial stress. And then there's a maternal and fetal risk of myelosuppression at delivery, which also requires significant timing issues. So generally accepted principles are that the health of the mother should come first, that chemotherapy should be avoided in the first trimester to avoid congenital malformation, that non-obstetrical surgery generally can be performed during pregnancy without increased adverse outcome, and that in most cancers, pregnancy doesn't adversely affect maternal prognosis compared with matched non-pregnant cancer patients, which is a very important point. What data do we actually have to guide decisions? So this is the reason that I don't have any specific expertise in this, which is that there are likely very few cases of dealing with pregnancy and cancer diagnosis concurrently for any single oncologist. It is estimated that there's between 0.02 and 0.1% of all pregnancies that occur with diagnosis of cancer, which amounts to about 1 cancer per 1,000 pregnant women. So obviously not very many physicians are going to have a large experience in dealing with this. So just to give you an idea of where we are with this, this was from a few years ago, but the most common types of cancers that are associated with pregnancy are cervical breast, melanoma, Hodgkin's, and lymphoma. Colorectal cancer didn't even make it onto the list for this. So as we see increasing numbers of colorectal cancer patients in the young population, this, we could anticipate, is going to become more of a problem. Can we get help from animal data? This is, of course, available preclinically with almost all new drugs, but human dosing obviously likely doesn't follow with this, so this is going to be of somewhat limited use. There are case reports and retrospective studies. These usually summarize information by chemotherapy agents or by cancer type. And the numbers per report usually range between 3 and 150 pregnancies treated with specific agents. There is also an impact of publication bias on this in that adverse outcome is more likely to be reported in case reports and favorable outcomes less likely to be published. One very important point is that we may have information about the effect of our drugs on the development of a pregnancy and on birth and on early infancy, but we have very incomplete understandings of long-term cognitive, cardiac, psychologic development and risk of subsequent malignancies in the children that are born to young women being treated for cancer during their pregnancies. So registries and databases would obviously be very helpful, but there are exceedingly few of these. So what I was going to do for most of the rest of this was go over what I think is some very important information that was recently published. And in fact, this article came out just a few days before Gianna's birth. This is a study on pediatric outcome after maternal cancer diagnosed during pregnancy, published in the New England Journal. And bottom line on this was that fetal exposure to maternal cancer during pregnancy, with or without treatment, didn't seem to have an adverse effect on cognitive, cardiac, or general development up to a certain time point in early childhood. So what they did in this study, and the reason that this is so important, it's not just a case report, it is actually a matched cohort. And this was conducted in Europe, in Belgium, Italy, Czech Republic, and Denmark. And pregnant women were enrolled through an international network on cancer, infertility, and pregnancy. And they were case matched from children in the general population born to healthy mothers in the same institutions who were recruited as controls to this trial. So this started out with 211 children who were born to mothers registered. 3 of these were colorectal cancer. And then they go through who was excluded and for what reasons, and ended up with an analysis of 129 children who were born to mothers who were pregnant had a cancer diagnosis during pregnancy. And as you can see, even in this study, most of them were tested for follow-up at 18 months. Fewer of them, only half of them, were tested at 36 months. So we still don't have a lot of data about long-term follow-up. This is probably a little difficult to see, but this is comparison of the prenatal exposure group and the control group, and they were fairly well balanced. One of the issues is birth weight below the 10th percentile, or small for gestational age. So 28 of the 127, or 22% in the prenatal exposure group, fell into this definition. Whereas 15% in the control group that did not meet statistical significance. So I wanted to just point out that one of the areas that did meet some statistical significance had to do with the prior educational experience of the mothers, which was lower in the prenatally exposed group. And the same thing occurred for the fathers. And the reason that this is important is that they're using particular educational scales which are impacted by the educational degree or experience of the parents. This is a table looking at how we looked at the whole group versus the small for gestational age group. And in general, we saw that for combined modality therapy, there was a larger percentage in the small for gestational age, but this is really informed by the fact that it was a smaller group. So this is sort of the meat of what they found in this study. They used a Bailey scale of infant development, which is an assessment of verbal and motor skills. Scores range from 50 to 150, and the mean is 100. Less than 85 is considered developmental delay. So what they were able to show in the first graph is that, I did that a little too soon, is that for gestational, per gestational age, the score goes up, increases 2.9 points for each additional week. I want to get out of that. But I think that this is really the important part, the forest plot, which shows that for cancer and pregnancy, all chemotherapy, specific chemotherapies, surgery alone, that there really is not a significant difference in the blue line, which is the cancer and pregnancy group, versus the control group, which is certainly a matter of some comfort. Oops, I don't want to do that. This is looking at echocardiographic findings, because heart development is also considered very important for exposure to chemotherapies in childhood. And there was very little difference. Mainly it was related to systolic and diastolic velocity. So their conclusions were that prenatal exposure to maternal cancer with or without treatment did not have an impairing effect on the cognitive, cardiac, or general development of children in early childhood. And that prematurity itself was correlated with a worse cognitive outcome, but that this also prevailed in the control group and was independent of cancer treatment. So moving toward conclusions about this, given the best available data that we have at present, it seems appropriate that maternal cancer can be safely treated in the second and third trimesters for both mother and fetus. Again, we do not have long-term follow-up following these children into the early teenage or young adult years. The ultimate decision has to be individual to the patient and based on the best information that we can discuss with the patient and family and her multidisciplinary care team. And we need to continue to improve upon the best available data to provide our patients to aid in these decisions. I mean, it's helpful that we have an article such as this coming out supporting these decisions, but it's still a fairly small group, and it would be helpful to have registries that would follow these individuals in a more comprehensive fashion. And that was the last point on that. I do have some references that would be available if anybody wants these, and I circled in red on the side where this work is being done. So the earlier reports, came from the U.S., but a lot of the comparative work is being done in Europe and Canada. And I thank you for your attention.